second question, it's related. Can we use it as a screening diagnostic tool to classify COVID suspect and probable patients? Maybe Dr. Answer can answer the second one. So, Pen, is it easy, a skill, easy to learn?
Basically, because I do a lot of regional anesthesia. So I already know how hypoechoic, those terms, those sonographic terms, anechoic, and how they look like. So when I started to learn point of care ultrasound, it was not hard for me because I already know the sonographic images and how they look like. But for other people, like if you are basically a newcomer into the world of ultrasound, maybe initially it will be like kind of a steep ladder. So you have first to become oriented with ultrasound images, and then perhaps from there, you can start learning all the other basics with lung ultrasound. Basically, it should be learning first all the lung signs. And from there, once you learn the lung signs, then you can gradually become more advanced and you start to try to diagnose other complexities on lung pathology, because point of care is not only lungs. If you have seen the lecture of Dr. Panzer, he has shown us a lot of other things which involve point of care, because if we diagnose lung pathologies, like for example, if we are considering pulmonary edema, the cause can be cardiogenic or non-cardiogenic. So you also have to look at the heart. So you cannot separate one from the other. And there are a lot of other entities to be studied with point of care. So it's quite a learning that is vast, but of course you start first from the basic and from there you progress. And then you have to keep on really attending workshops and then apply it when you go to your hospital.
Thank you very much, Pen. So the answer is, it's easy but not easy. But you can teach old dogs new tricks. Can we?
Right.
Pen?
Right.
Right. Okay. Okay, Dr. Panzer, can we use it as a screening or a diagnostic tool to classify COVID suspect and probable patients? What do you think?
I think to be honest with you, from the COVID patients that I've seen, the lung ultrasound is sort of not necessary to classify, because it's a clinical assessment, right? I mean, they are very, very hypoxic, and by that, you can confirm a lung process and then confirm ultimately that this COVID patient has COVID ARDS. But I think to classify them, they do have, even those that have milder symptoms, do have quite a bit of lung pathology already. So I didn't find it that useful to kind of help me, decide, for example, a need for intubation or not, or, determine the course of it. But I did find it helpful to kind of see if I have signs of improvement or signs of worsening and judge my therapy therefore. I think for classification, the clinical aspects are probably what drives the decision.
Very well said, Dr. Panzer. Okay, there's another question, Dr. Panzer. I think you will be able to answer this. The question is, since ultrasound is a real-time diagnostic tool, can we use it also to check if mechanical ventilation settings are able to open up spaces, or identify if there are fibrotic changes in the lung parenchyma already? So
this is a great question. Actually, yes, I think you can, and that's what I was alluding to by describing the lung findings as a continuum of worsening or improving. So there's actually nice studies out there that use that in critically ill patients on the ventilator to see if a pneumonia is improving. So meaning, does a consolidation go from consolidation to confluent B lines, or even separate B lines, then that is a clear sign of improvement. And I do think that it is very useful for that, to actually see if you're making progress. Now, the last question is actually tricky. You mentioned lung fibrosis. And for lung fibrosis, that looks very similar to spread out B lines. I don't think it typically comes with confluent B lines. It's more like separate B lines because of the fibrotic process. But you cannot distinguish them from an acute process. So they look very, very similar. So the only way, and I've mentioned this a couple of times, I think the key with doing point of care ultrasound in many aspects is the key is to do it repeatedly. So you track your patient over time, and then you get additional benefit to see, because if you start then a patient that comes with pre-existing disease like lung fibrosis, but you know that from the beginning, you'll be able to change your clinical assessment as if you didn't know that, or let's say the patient initially did not have a lot of B lines and then chose to have a lot of B lines, lung fibrosis is unlikely. Then, the reverse, of course, is true. If the patient gets better, and we know from reports that these patients exist that develop persistent lung fibrosis afterwards, the lung exam just doesn't change, right? So the B lines stay there, even though the COVID in and of itself is the virus and the inflammation is gone. So fibrosis so chronic versus acute changes, hard to make that diagnosis specifically with a lung ultrasound exam without having the clinical information and a time course.
Thank you very much, Dr. Panzer. This next question is directed to any of you. How do we differentiate a consolidation of pneumonia versus collapse? Ben, maybe you can answer first.
No, Dr. Panzer will answer that. He has more experience on consolidation and collapse.
So there are different signs from collapse. So typically a collapse is by external pressure. And so you have to have signs of that. And classically, in our case, that's a large pleural effusion. So it's hard to think of a collapse if you don't have a compression. And with a compressive atelectasis, a true collapse by external pressure, you don't have other signs like what I mentioned earlier, the air bronchograms, which are white dots within the solid lung, or black dots or streaks within the solid lung. That doesn't happen with a complete collapse from external pressure. Pneumonia, you can actually diagnose now fairly reliably, because there is a list of criteria that make a pneumonia more likely. But again, the key mark is here, it fits the clinical picture. But if you have a clinical picture that could suggest pneumonia, and you have a thickened pleural line, a fragmented pleural line in one area, if you have dynamic air bronchograms, I showed you one picture where the line actually extended with an inspiration inside the consolidation. This is very typical for pneumonia, because what it tells you is that if the air bronchogram is moving back and forth, there's still air being pushed into that segment of the lung. So it cannot be a complete mucus plug and occlusion that caused this consolidation of the lung. So this dynamic air bronchogram, the change of the pleura, and typically a very small pleural effusion rather than a large one around it, make the diagnosis of a pneumonia very likely. Again, I want to highlight in the right clinical scenario, meaning I have signs of infection that would explain that.
Okay, thank you very much, Dr. Panzer. Another question for you, Dr. Panzer. It seems you have a lot of fans over here. The question is, will the signs of, I'm just going to rephrase the question, will ARDS signs will show specific signs under ultrasound. How about COPD? Will it show specific signs under
Yes.
ultrasound?
So
ARDS.
you mean ARDS in a COPD patient?
Maybe
Is that what?
I think it's a different scenario. What signs will
Yeah.
appear in ARDS and what signs will appear in
Okay.
COPD under ultrasound?
Good. So yeah, they're very different. In ARDS, we talked a lot about it. We talked about all the signs, and basically all these signs are absent in COPD. COPD is going to show you a very clean lung, meaning in the sense that you're going to have a pleural line and A lines, tons of A lines. The thing is that there in COPD as well, though, the lung sliding will be very reduced. It's going to be hard to see. You would typically, what I do if I don't see it very well on the cardiac probe, I switch to a linear probe because I have a higher resolution to detect really small movements along the pleural line. Because in a COPD patient, the lung is overblown. And so it's very extended, so you're not going to see the lung sliding very well. But the hallmark is that COPD looks like a normal lung, but the patient is very symptomatic. So if you have normal lung and you have a patient who's hypoxic, then COPD, asthma are two diagnoses that immediately pop into your head, including PE that also would show in a severely hypoxic patient, would show a grossly normal lung.
Okay, thank you. Now this is a question addressed to Joseph Kudyamat. Joseph, how much is a piloter? The question is how much is a piloter? Yes. Maybe this.
Doc, we will send the price quotation once we get the details of the person asking.
Okay.
Because right now it's highly volatile due to COVID season for the shipment. It's very unstable.
Okay.
But rough estimate, it will run to between 800 and to 1 million.
Okay. So we'll send the details to Dr. Arnel Asino. Okay.
Thank you, Doctor.
Okay. So another question to Dr. Panzer again. How reliable is the IVC diameter and other indices to assess fluid volume to rule out a shock or a volume overload?
So that's very good question, very important question. The IVC is easy to assess, and therefore IVC parameters like the variation in diameter have gained a lot of popularity to assess volume response. Unfortunately, this test is very inaccurate. So I would not recommend to decide on a giving volume based on just assessing the variation in size of the IVC. I can tell you just this question alone, I could give you at least 1 hour talk to get through all the different methods of volume responsiveness. What I do think the IVC is very valuable for is to assess extremes, meaning what I highlighted in my talk is that if I do think that the shock, high dose pressors, increased lactate, cold, clammy extremities is caused by hypovolemia, the IVC will not be plump. It will be collapsed. It will be very small. In that way, but that's a very extreme situation. Most of our patients are in the gray zone, where I have a little bit elevated pressors, but my IVC is not completely collapsed. It's just like oscillating a little bit. And I feel like that is not a good tool to make that decision. Should I give like 500 cc's a liter? And maybe that's going to go better, because the downsides in ARDS patients who already have a very poor lung function, if you give a liter based on an IVC exam, it may cause you more harm than benefit. So what I like to use the IVC for is